Pulmonary cavities. Pulmonary cavities are thick-walled abnormal gas-filled spaces within the lung. They are usually associated with a nodule, mass, or area of consolidation. A fluid level within the space may be present. Plain radiography and CT form the mainstay of imaging. They may develop as a chronic complication of a pulmonary cyst or secondary to cystic degeneration of a pulmonary mass. They may enlarge or involute over time. Differential diagnosis of cavitary lung lesions. Many different diseases present as cavitary pulmonary nodules. The spectrum of diseases ranges from acute to chronic infections, chronic systemic diseases and malignancies. Pulmonary cavities may be the result of a congenital. To decide on the most likely or correct diagnosis may be challenging. Knowledge of common and uncommon radiological findings in correlation with relevant clinical history and findings is necessary to make the right diagnosis and recommend the correct follow-up or step forward. The aim of this pictorial review is to present a brief overview of CT findings of common cavitary lung diseases seen in adult patients. Cysts in the lungs are defined as any round circumscribed space that is surrounded by an epithelial or fibrous wall of variable thickness. The glossary further defines them as usually thin-walled, measures less than 2 mm in size. A recent study found that a wall thickness of less than 7 mm was highly specific for benign disease, and a thickness of greater than 24 mm was highly specific for malignant disease. An additional indicator for malignancy was the lack of perilesional centrilobular nodules, whereas perilesional consolidation was common around benign nodules. The content of the cavities is of little help in differentiating benign and malignant lesions. A benign bronchogenic cyst may contain fluid levels, as may a bronchoalveolar carcinoma. The degree of contrast enhancement in the content of nodules less than 10 Hu is shown to indicate benign lesions and may be used to distinguish aspergillomas from lung cancer. Rim enhancement of the walls on contrast-enhanced CT is common in abscesses. A connecting pulmonary artery may be seen in smaller metastases but not in larger ones, as the larger nodules tend to compress the vessels, so a lack of a feeding artery cannot be used to imply benign nodules. The acute onset of symptoms is sometimes helpful to distinguish malignant and non-malignant disease, but a benign infection may, for instance, cause hemoptysis when affecting a nearby vessel. Benign diseases may also cause fatigue and weight loss similar to malignancies. Acute onset of fever is usually helpful to distinguish benign disorders from malignancies, but a pulmonary cancer may present with a superinfection secondary to the tumor. However, the combination of symptoms, laboratory results, past clinical history, and imaging findings leads to recognition of the correct diagnosis.